So to talk about extremes, we've gone from healthy lifestyle, and we're going to now focus on critical limb ischemia. And this is the complete opposite of a healthy lifestyle. This is patients that have had advanced PAD for years or unmanaged risk factors for years, and the consequences of this. And so we need to see that dichotomy so that we can really start to figure out how to kind of approach this. Our first speaker today is going to be will be Fadi Saab. He is a board-certified internal medicine and specialty in cardiology and interventional cardiology. He is a clinical associate professor of medicine at the Michigan State University College of Human Medicine, and he co-founded Advanced Cardiac and Vascular Amputation Prevention Center back in 2017. He's a personal friend. He is a visionary and a leader in critical limb care. He has authored over 25 peer-reviewed publications and is involved in multiple, I think over 15 different clinical research trials. He's an excellent speaker, and I'm looking forward to hearing his talk. Our next speaker directly after that, will be Jill Somerset, RVT. She is a registered vascular technologist working out of Peace Health. She is the technical director of that lab with over 20 years experience, and she has a deep interest and passion for critical limb ischemia. She leads a multidisciplinary limb salvage program at Peace Health and is known nationally and internationally for the concept of pedal artery acceleration times. We call it PAT for short. She is the lead author and for the peer-reviewed publications on this subject, and we currently at Vic use her protocols. So I'm looking forward to her talk. Additionally, Monica Chamberlain, DNP. She is a nurse practitioner with a doctorate in nursing practice. She manages Vascular Institute of Chattanooga, all hospital-related responsibilities. She has a doctorate in nursing and 2 master's degrees from Southern Adventist University. And she'll be speaking about the proper workup for acute and chronic critical limb ischemia. And then lastly, I'll be the speaker. I'm Chris Lassar, currently the moderator for this session. And I had my degree from University of Toledo for College of Medicine for my medical degree, as well as my surgical fellowship, and then Eastern Virginia Medical Center for my vascular fellowship. I've been involved with surgery for over 20 years and a true passion for critical limb ischemia for the last 10. I started a company called Vascular Institute of Chattanooga 5 years ago to change how we address vascular care in our region and try to amp up the experience for our patients in this region. I've been involved with multiple research publications, and I speak nationally and internationally on the subject of CLI. So with that, we're going to start off with Dr. Fadi Saab, and I'm looking forward to hearing about critical limb ischemia and understanding this process and how we handle these patients.
Hello, my name is Fadi Saab. I am the Chief Operating Officer and Interventional Cardiologist at Advanced Cardiac and Vascular Centers in Grand Rapids, Michigan. It is my pleasure today to participate with you in Faces of PAD. I want to thank the organizers, and I want to thank Dr. Lassar for the kind invitation. And I was tasked to discuss a little bit about the problem and importance of critical limb ischemia in the current day and age. These are my disclosures. So critical limb ischemia is a condition that is underdiagnosed and is undertreated. It's a deadly disease that requires proper diagnosis, it requires proper imaging, and most definitely requires increased awareness on a societal level and in terms of also our healthcare providers. Peripheral arterial disease of the lower extremity is a global pandemic, and unfortunately it has growing proportions. World population increased about 12.6% between 2000 and 2010, and PAD increased twice as much during the same period. And when you start thinking about the global burden of the disease, there are about 202 million adults worldwide that are suffering with peripheral arterial disease. And peripheral arterial disease has a higher prevalence than ischemic heart disease, 154 million, and I'm a cardiologist. Heart failure have a higher prevalence in Alzheimer's disease than cancer, HIV, and opioid addiction. And unfortunately, the prognosis after peripheral arterial disease diagnosis is poor because the disease often progresses to the extent that distal perfusion is insufficient to meet the metabolic demands of the body, especially and particularly in the cases of critical limb ischemia. This advanced PAD form is commonly described as critical limb ischemia, and it represents end stage, the final destination of the disease, and it's mostly characterized by occlusive disease of the tibial and foot arteries, in which patients suffer from one or more of the followings: either rest pain, ischemic ulcerations, limited to skin breakdown in some conditions, and ultimately significant tissue loss, or what we would describe as gangrenous tissue loss. Now, CLI is more common than what we think. The ratios that are placed out there in terms of diagnosis of critical limb ischemia is definitely underrepresenting the true numbers of critical limb ischemia. And among in the United States, so there's about 9 to 20 million adults with PAD in the United States, and 11% suffer from critical limb ischemia, which is a huge departure from the number of 1 to 2% thought process that only the minority, or the very, very small minority of patients with peripheral arterial disease progress to critical limb ischemia. And the more contemporary set of data argues otherwise. Now, CLI prevalence is typically estimated from administrative claims databases using ICD clinical diagnosis codes. And these diagnostic codes yield high sensitivity when in patients with critical limb ischemia diagnosis code have the disease. However, there is a loss of specificity when patients without critical limb ischemia diagnosis code may actually have the disease. So, with the ICD-9 older codes, there were rest pain, ulceration, and gangrene. Yet there are numerous complex critical limb ischemia presentations possible that would be excluded from this simplistic CLI code diagnosis. For example, when a patient is diagnosed with PAD and diabetes and who undergoes above the ankle amputation, validation studies suggest that the use of administrative codes for CLI diagnosis may underestimate the true prevalence by almost 25%. Given these factors, it can be estimated that between 1 to 3 million Americans suffer with critical limb ischemia. So what is it that's known about critical limb ischemia currently? The diagnosis of critical limb ischemia portends to grave prognosis that is more fatal than any other deadly cancers. And it's a really bold statement, but I'm going to show you some data that's going to convince you that unfortunately, for the lack of a better term, you rather be diagnosed with cancer or some cancers versus having the deadly diagnosis of critical limb ischemia. There's a mortality risk of 24% over 1 year in patients with critical limb ischemia and 60% over 5 years. And this is one of the slides that our group with the CLI Global Society have created, and it's somewhat of a busy slide, but if you look on the x-axis, this is the incidence of cases in the United States, and on the y-axis, there is the death rate within 5 years. And if you look at the red dot of critical limb ischemia, well, the prevalence is somewhat in the middle of some of these cancers, but the mortality rate associated with it, with critical limb ischemia, is worse than colorectal cancer, is worse than some of these ovarian cancer, is worse than myeloma cancer, and you can take a look at all of these diagnoses that are pushed there. And because CLI is both common and deadly, more incident cases die over 5 years after a CLI diagnosis than with any other type of cancer, except for lung cancer. When comparing incident cases of critical limb ischemia and 22 types of cancer, the disease responsible for the most deaths over 5 years in the US are lung cancer, 192,000, critical limb ischemia, 58,000, pancreatic cancer, 51,000, colorectal cancer, 49,000, and liver cancer, 35,000. And overall, the high incidence of CLI in combination with its highly fatal course makes this disease an under-recognized and major threat to public health. And it's undertreated. Adding to the poor prognosis after the diagnosis of critical limb ischemia, patients with this disease remain underserved with regard to diagnostic evaluation, medical therapy, and utilization of revascularization. And societal guidelines recommend that all individuals diagnosed with critical limb ischemia undergo an imaging study to assess the viability of endovascular or surgical revascularization. However, and this is the shocking part, angiography is only performed in approximately 1 out of 4 patients, despite patients who undergo angiography have a 90% lower risk of major amputation than patients who do not undergo angiography. Additionally, because patients with critical limb ischemia typically present with extensive comorbidities requiring optimal medical therapy, however, less than 1/3 of patients with critical limb ischemia are prescribed optimal medical therapy. Now, limb amputation is too often the primary treatment for critical limb ischemia without first considering whether revascularization is feasible, which is concerning disservice to those patients. So critical limb ischemia is the only disease where amputation is considered a first line of therapy, which is not acceptable or should not be acceptable by our modern standards. And even more perplexing, about 30% of patients who underwent major amputation presented with rest pain or ischemic ulcer, but not necessarily gangrene. And compared to revascularization, amputation doubles the risk of death over the next year, even after controlling for important confounders such as age, disease severity, diabetes, and chronic kidney disease. And furthermore, in patients with gangrene in whom many healthcare providers may believe major amputation is the only viable first-line therapy, endovascular and surgical revascularization double patient survival compared to amputation. So overall, doing something and revascularizing those patients is a better alternative than having a major amputation. Now, awareness is an important key point here. In 2013, President Barack Obama signed into law an act to develop nationwide strategic plans to address the nation's deadliest cancers. And it's called the Recalcitrate Cancer Research Act. This is defined as those with 5 years mortality rates greater than 50%, which includes cancers of the pancreas, lung, brain, esophagus, liver, ovary, and stomach. More people die from critical limb ischemia each year than cancers considered to be one of the deadliest. Unfortunately, there is no such legislation pending for critical limb ischemia, even though the 5-year mortality for critical limb ischemia patients is greater than 50%, and the annual incidence of critical limb ischemia is greater than that of esophageal cancer, stomach cancer, brain cancer, and ovarian cancer combined. So a recent study that we looked at within the Critical Limb Ischemia Global Society, looking at the long-term outcomes and costs in the management of critical limb ischemia patients, we found that CLI obviously is a serious problem. Hopefully I convinced you with some of the data points that I showed you. Revascularization and attempts to salvage the limb are effective in saving both limbs and reducing mortality for those patients. And that's a huge key point here, that actually achieving revascularization for those patients might contribute to decreasing their mortality rates. And considerable efforts are needed to raise these awareness and implement coding to better define and identify the disease. So this should be no surprise. A primary major amputation results in shorter survival, higher risk of subsequent major amputation, and a higher healthcare cost versus revascularization. And when we conducted a multivariate analysis of mortality and major amputation risk following diagnosis of CLI. If you look at patients with rest pain, ulcer, and gangrene, the higher the degree, or the higher the degree of, or the worse degree of critical ischemia, the higher of a negative impact amputation would have on the patient, and the higher the risk of mortality for those patients. So the mortality of patients with gangrene that undergo major amputation is almost 2.5 times more than the general population. Now, patient survival and freedom from major amputation through 4 years were higher in patients with gangrene. Among patients who underwent major treatment, 4-year survivals were 45% for endovascular revascularization, 51% for surgical revascularization, and 21% for major amputation. The point here is revascularization for those patients is definitely a positive impact on those patients overall. And patient undergoing primary major amputation had the worst prognosis across each clinical presentation category, with 4-year survival of 34% of those patients with breast pain, 22% with an ulcer, and 20% with patients with gangrene. And obviously, unfortunately, the survival of those patients over 4 years also is worse based on the degree of critical limb ischemia. And freedom from major amputation over 4 years following the diagnosis of critical limb ischemia in the entire sample shows that, again, revascularization for those patients tend to have a better outcome. So patients who undergo primary major amputation have poor prognosis even when adjusting for demographics, medical history, and disease severity. And compared with revascularization, primary major amputation is associated with shorter survival time, increased risk, and second major amputation, and a higher healthcare costs overall for the patients. I'm going to stop here. Again, I want to thank the organizers for inviting me. I hope that you'll find this information, some of these data points, although it's laborious, and but I hope that you will find it intriguing, and it will help arm you increasing awareness, because we are the first line of defense for a lot of those patients. Thank you very much, and I hope to see you next year. Thank you.
Good morning, everyone. Thank you, Dr. Lassar and Faces of PAD Committee, for the invitation to speak at this meeting. Here are my disclosures. Current non-invasive arterial testing consists of ABIs, which we know can be erroneous in the diabetic or renal failure patient. We then look to TBIs, or evaluate the toe waveform. However, this can be challenging with a complex wound or a missing digit. We then rely on the lower extremity arterial duplex ultrasound, which can provide tremendous information, however, historically has stopped imaging at the level of the ankle. We then rely on TCPO2 to evaluate perfusion in patients with non-healing wounds. I'm pleased to introduce to you pedal artery duplex ultrasound, which provides so much helpful information in patients with complex disease and significant foot wounds. We have found incredible value in duplex ultrasound of the pedal vessels, where we can evaluate blood flow right to the edge of the wound bed. In this new discovery of pedal arch duplex ultrasound, we can identify 3 key components of advanced duplex ultrasound of the foot, which includes perfusion, anatomy, and technology, which is the flow direction of the pedal vessels. Let's first take a look at perfusion. A new technique called pedal acceleration time, otherwise known as PAT, is the extension of the arterial duplex ultrasound done at the bedside. This is where we can precisely measure the onset of systole to the peak of systole of the pedal artery arterial waveform, measuring the time it takes a red blood cell to get from point A to point B, and we can classify the pedal acceleration time into 4 classifications. Our criteria has been published in the Annals of Vascular Surgery and ranges from class 1 being normal to class 4 being consistent with tissue loss and rest pain. This new technique is really incredible when we want to get right to the edge of the wound bed, when all of our other diagnostic testing may be erroneous or cannot answer the clinical question. To review the pedal anatomy, we know that the arcuate artery and the dorsal metatarsal artery make up the anterior circulation. The medial, lateral, and deep plantar arteries make up the posterior circulation. We do not average these times. We look at them separately depending on the angiosome of the foot wound. This is how we image the anterior circulation. You can see the probe placement in the distal dorsalis pedis artery, and we see the bifurcation of the arcuate artery and the dorsal metatarsal artery. And as you can see here, in patients with no digits or complex wounds, this patient on the top has been revascularized. We want to ensure that they have adequate flow. And in both situations here, these patients have class 1 pedal acceleration time, indicative of adequate perfusion to the foot. We can also image the posterior circulation, which is the medial plantar artery, which is oftentimes smaller in caliber and more superficial. We can appreciate that angiographically as well. And the lateral plantar and deep plantar are typically more dominant, and we can also obtain a pedal acceleration time in these vessels as well. And as you can see, this technique is very helpful in these patients who have had a TMA on the top picture or a first ray amputation as seen in the bottom picture. If you're having trouble imaging the lateral plantar artery, you can turn the probe in transverse and image the plantar veins that surround the plantar artery. You can see the metatarsal bone as our landmark, and then you can do compressions of the lateral plantar veins to identify the lateral plantar artery. We do use veins as our landmark. We want to make sure that our color scale is appropriate. This is what it looks like with no color, and you'll note that the lateral plantar vein is oftentimes very generous, and again, a very good landmark for identifying the lateral plantar artery. Like with anything, there is a correct technique. So when we image the pedal vessels, we want to decrease our color scale, make our box small, and appropriately adjust all of our settings. When we apply Doppler, we want to decrease our scale, increase our sweep speed, and precisely measure the onset of systole to the peak of systole to obtain a pedal acceleration time. We validated our criteria by retrospectively reviewing 499 limbs. All patients had reliable ABIs. They were non-diabetic and non-renal failure patients. We found a statistically significant correlation between PAT and ABIs, and that is how we validated our criteria. PAT not only correlates with ABIs that are reliable, but more so it correlates with clinical symptoms. We did have outliers in our study with an abnormal ABI and a normal PAT. And these are patients that did not have any claudication symptoms, but did have an occlusion of their SFA. The beautiful thing about PAT is that it captures all of that collateral flow coming off the profunda. So PAT does a fantastic job at capturing all of that collateral flow, and that is why PAT correlates with clinical symptoms. Nothing is perfect, and PAT does have limitations, so let's discuss them. The first limitation is hemodynamically significant isolated inflow disease, a PAT of greater than 300, a flow velocity of less than 5 centimeters per second. There's always tech-to-tech variability. And then fifth is low cardiac output. In the setting of isolated significant inflow disease, a patient may have patent infrainguinal and infrapopliteal disease. However, the PAT may present as normal in the foot, but you'll note that the velocity is typically of less than 5 centimeters per second. In this situation, we cannot rely on PAT. Another limitation is a PAT of greater than 300. It still puts it in the class 4 classification of severe ischemia in the pedal arch. We just are pushing the limits of ultrasound. This is nearly a continuous Doppler waveform indicating severe disease. A limitation is also the velocity. So if the velocity is less than 5 centimeters per second, we cannot adequately measure pedal acceleration time. It doesn't mean that we should throw out the data. We should understand what it means. So in this first situation, this patient has a low cardiac output of 15%. In this situation, this patient has ischemic rest pain. There's always tech-to-tech variability. Technique is a huge limitation. We have to do this technique correctly. So having a very high scale is incorrect. We want to decrease our scale, make our waveform very large so we can accurately measure the acceleration time. Moving on to anatomy, we now have this incredible view of any anatomical variation that may be present. In this situation, this patient's TMA is falling apart. This patient has zero flow in this territory of the foot. So understanding the anatomy is very important. And this is why we take all 5 sites of the pedal arch, because we want to understand the anatomy. Technology has improved so much that we can image the pedal vessels, but we can also identify flow direction, which can be very helpful in the setting of more proximal significant disease. We published our paper in the Journal for Vascular Ultrasound identifying pedal flow hemodynamics in patients with CLTI. And what we found is patients with proximal disease in the anterior circulation, we will likely see retrograde flow in the arcuate artery. This can be very helpful if there is a great toe wound and we cannot revascularize this anterior circulation. We may need to indirectly revascularize to that great toe via the retrograde arcuate artery. And this is what happened in this situation. This patient's dorsalis pedis artery is occluded and he has retrograde flow coming from the posterior circulation. So this is a retrograde arcuate artery being fed indirectly from the posterior circulation. After revascularization, this patient's PAT is class 1. Conversely, if the patient's posterior circulation is significantly diseased, the likelihood of seeing retrograde flow in the deep and lateral plantar artery is very high. Again, this is helpful in the setting of a heel wound where we need to indirectly revascularize that territory of the foot if the posterior tibial artery is occluded. This is a 68-year-old female who presented to the ED with bilateral foot gangrene. She has the typical comorbidities of diabetes, hyperlipidemia, and hypertension. She's a former significant smoker, however, has since quit. Upon arrival, she had absent common femoral artery pulses, popliteal, and pedal pulses bilaterally. Unfortunately, due to her diabetes, her ABIs are non-compressible, and we could not obtain TBIs due to bilateral toe gangrene, and her PAT bilaterally was class 4. Through staged procedures, the first stage was establishing inflow, so there was bilateral common iliac artery stenting with bilateral common femoral artery cutdown and endarterectomy. The next stage was bilateral fempop bypass graft. So let's focus on the left side. After all that intervention, we've established inflow and outflow, and she had 4-foot amputation. Now on this side, the patient had 2 vessel runoff from the posterior tibial artery and the perineal artery. So she has an occluded anterior tibial and dorsalis pedis artery. Throughout all that revascularization, her PAT is now class 1 throughout the course of wound healing. And this is what it looks like by duplex ultrasound. Remember, this dorsalis pedis artery is occluded, so we see retrograde flow in the arcuate artery with antegrade flow out the dorsal metatarsal artery. And again, class 1 PAT. When we turn our attention to the right side, after all of her stage revascularization, and her PAT throughout the course of wound healing also remained of class 1. We followed our patient throughout the course of wound healing during her wound vacs and through repeat follow-up office visits to make sure that her PAT stayed of class 1. Unfortunately, there was a stall in her wound. This started to break down and this started to open up. So straight away, we did a pedal acceleration time and found an interval change on the left from class 1 PAT to now class 4. She bought herself an arterial duplex ultrasound and found that she had a high-grade lesion of her distal anastomosis of her fempop bypass graft. We then looked at the right PAT and again had an interval change from class 1 to nearly class 4. And again, she had a distal anastomosis stenosis with mid-graft velocity being abnormal at 26 centimeters per second, which is indicative of graft failure. So we confirmed this with angiography. You can see we did balloon angioplasty of the distal anastomosis, and we saw the same thing on the right. So we did balloon angioplasty of that distal anastomosis and tibial perineal trunk. Post-op intervention, we cleaned up her wounds, and rescanned her, found an interval change in her PAT to now class 1. So this is the left side. We see her lateral plantar artery quite nicely, which her PAT is now class 1, as well as her retrograde arcuate artery. And then on the right, we also saw an improvement to class 1 in the entire pedal arch in this right leg. So this is a patient that could have easily ended up with a bilateral above knee amputation. And as you can see here, like all of us, we work so hard to prevent amputation. So when a patient can walk out, that is a day to celebrate. So in summary, this new perspective of pedal artery duplex ultrasound is quite incredible. We now can tell you the perfusion, understand the anatomy, and the flow direction of these patients with complex disease and complex wounds. We follow them preoperatively, during the intervention, and postoperatively. I'm excited to share our global collaboration of pedal acceleration time and really look forward to the data that will come out as we progress through these research projects. So in summary, pedal acceleration time and pedal artery duplex ultrasound is an exciting new territory to explore. It provides a new perspective in the complex CLTI patient, and we hope that we can improve patient care and decrease the rate of unnecessary amputations. Thank you so much for your time and attention.
Hi, welcome to Faces of PAD. My name is Monica Chamberlain, and I'm a nurse practitioner who works for Vascular Institute of Chattanooga. I am the hospital nurse practitioner, and my specific role is to round on all the post-op patients and evaluate all the new consults. I go to all the local area hospitals in Chattanooga and Cleveland, Tennessee. For the Faces of PAD conference, Dr. Lasar has asked me to talk about the proper workup for critical limb ischemia. Sadly, I have no financial disclosures to report. The objectives for this talk is to recognize critical limb ischemia by physical exam, to know what diagnostic tests to order, and to how to interpret those results, and to know whether immediate surgery is needed versus non-emergent surgery. So what is critical limb ischemia? It is defined as limb pain that occurs at rest or impending limb loss that is caused by severe compromise of blood flow to the affected extremity. Just this week, I had a new consult that I needed to see, and when I walked into the room, the patient was laying on the bed with their leg hanging off the side of the bed. The number one sign of rest pain is hanging the extremity down. This is due to gravity helping to pull the blood down to the tissue that's screaming for oxygenated blood. It's the body's natural way of trying to fix the problem. So just like with stroke and with heart attack victims, with critical limb ischemia, we have a narrow window of time to revascularize before there is tissue damage. So time is tissue. Cell death begins after 4 hours of total ischemia, and it's irreversible after 6 hours. So we start at the beginning with a good history and physical. I ask them how long that they've had these symptoms. Has it been hours? Has it been days? Have they had any revascularization issues in the past? Do they have previous peripheral stents or coronary stents? What kind of risk factors do they have? Diabetes, kidney issues, smoking, coronary issues. I also ask them claudication symptoms. I ask them how far that they can walk. Do they have to stop and rest and let their tissues reoxygenate before they can keep going? We use a classification system for claudication. There's two different systems, the Fontaine and the Rutherford. At Vascular Institute, we use the Rutherford. It's grade 0 to 6, with 4, 5, and 6 being the most damaging. Grade 4 is ischemic rest pain. Grade 5 is minor tissue loss. And number 6 is ulceration with gangrene. I have some slides that show the Rutherford 4. So this, you can see that it's these patients have redness here on their lower extremity and on their feet. We call that rubor. And then with Rutherford 5, you can see that these patients have started some tissue loss. There's some ulcerations and the beginning of a little bit of gangrene on that big toe. And then here, there's obvious tissue loss and tissue damage with ischemia. And then we start with the physical exam. I ask them, do they have sensation? So I touch their feet. A lot of these patients have neuropathy. So a lot of them can't feel their feet, but they do have pain with rest pain. I will touch all the way up their leg and see where they can feel. I ask them about their motor function. Can they move their toes? Can they move their foot? Can they move their leg? And then I assess the temperature of the lower extremity. Is it warm? Is it cold? Usually with critical limb ischemia, their foot will be extremely cold because there's no blood supply. Then I look at the color of their extremity. Typically with critical limb ischemia, it's completely white because there's no blood flow. Sometimes it'll be kind of a cyanotic purple color. Then I assess their feet and their legs to see if they have wounds. Again, looking at the Rutherford system, are they in the category of 4, 5, 6? And then I do a pulse assessment. So I try and palpate first their femorals and their dorsalis pedis and their posterior tibial. And if I can't palpate, then I use the Doppler. After I assess the patient, I determine what diagnostic imaging is needed, and I use the ones that will yield me the greatest results in the shortest amount of time. Usually we try to do the least invasive and the cheaper diagnostic testing first. This is usually an arterial ultrasound. It can give us some really good information and helps to direct us in our treatment plans. Ultrasounds are helpful because they can show the anatomic level of disease and or stenosis by waveforms. And what do I mean by waveforms? Glad you asked, because I have little clips here. The first one is triphasic waveforms, and that's a normal flow pattern. The second is a biphasic flow, and that shows some moderate blood flow issues. And monophasic is always abnormal. Ultrasounds also record velocities of the arteries. Increased velocities indicate the severity of a stenosis, but there's also very low velocities indicate low blood flow or near stenosis. The normal peak systolic velocity, or PSV, is 100 to 180. We also use ABI to assess the blood flow to the lower extremities. The ABI is ankle brachial index. It's obtained by a blood pressure cuff close to the ankle and the blood pressure cuff at the brachial artery. The cuffs are inflated and the ankle systolic pressure is divided into the systolic brachial artery pressure. Normal is 0.9 to 1.3. Moderate is 0.4 to 0.9, and critical limb is considered anything below 0.4. It is important to note that with diabetics or renal failure patients, calcific sclerosis along the artery walls may falsely elevate the ABI values because of non-compressible vessels. So that's why it's important to know if these patients have diabetes and renal issues. Toe brachial index is a similar concept, except for the BP cuff is fitted around the big toe. And this is a good indicator of wound healing potential. Normal for TBI is 0.5 to 0.7, and anything less than 0.2 indicates severe ischemia and poor wound healing. I've got a couple of results from ultrasounds from Vascular Institute, and you can see on this one, the first one, ABI on the right is 0.59 and ABI is on the left is 0.77. And then the toe pressure on the right is 0.18, so that's less than 0.2. And then the toe pressure on the left is 0.28. On the Next one, the ABI is 0.83 and 0.38 on the left. So that's low. And then the toe pressure on the left is a 0. So you can see that that would indicate critical limb ischemia. And you can also see that on the left, you have sharp monophasic and absent waveforms. This next ultrasound report showed occlusion all the way down from the SFA all the way down. And here's a little stick figure. This patient came into the office complaining of leg pain, and you can see she had no blood flow. That goes all the way down from the very beginning. Next, we can use a CTA. So a CTA with runoff to the lower extremities is useful. It can determine if there is a narrowing or a stenosis higher up than what is found on the ultrasound. If the velocities of the common femoral are low, then there indicates that a problem is upstream and we need to look higher, like the aorta or the iliac. But prior to ordering a CTA, we always need to check the renal function because this uses IV contrast. If there are deep ulcerations or gangrene present, I will often get an X-ray or preferably an MRI to determine if there is osteomyelitis present. If a patient is not able to have an MRI, a bone scan can be done as well. If there is obvious purulent drainage from a wound, I'll get a culture and send that to pathology prior to any antibiotics or procedure being done. Sometimes a diagnostic angiogram or aortogram is warranted if the symptoms or a presentation of a patient does not match what the ultrasound results show. However, this is the most invasive and it does use contrast, but it also gives the best information since it's a direct look into the vessels. So that brings me to my case study. Not too long ago, I had a patient, he was 46 years old. Past medical history was diabetes, hypertension. He had peripheral artery disease, neuropathy, and diabetic foot ulcers. Past surgical history, he already had a right TMA, transmetatarsal amputation, and he had a recent left toe amputation. He presented with an infection of the left fifth toe amputation site on the plantar aspect of his foot. He did have an MRI and it was concerning for osteomyelitis. The surgery he had with podiatry, an incision and drainage with bone removal due to the osteomyelitis. And vascular was consulted because podiatry noted very little blood flow during surgery. So that was obviously a little concerning. Interesting to note that he had had previous revascularization done to that lower extremity about 5 months ago. So I ordered an ultrasound, an arterial ultrasound, and you can see on the left iliac artery, all the velocities there, they look all within normal range. And it said, the impression was there is no occlusion or significant stenosis with primarily triphasic waveforms. If you remember, triphasic was the best waveform. However, things didn't sound right and didn't look right with this presentation. And according to podiatry, they didn't see very good blood flow during surgery. So there was a difference of the presentation and what the ultrasound was saying. So I had this guy go for a diagnostic angiogram, and he ended up having an atherectomy and angioplasty of the left anterior tibial artery. He had angioplasty of the posterior tibial artery and the dorsalis pedis artery. And he did end up with a stent to the left SFA. So the takeaway is to look at your patient, get a good history and physical, know your diagnostic tests, but always treat the patient, not the test results. For critical limb ischemia, remember, time is tissue.
Good morning, and thank you for being involved with the Faces of PAD program. My topic today is putting it all together, advanced CLI care, a case-based approach. I'm Christopher Lasar, and I work at Vascular Institute of Chattanooga. VIC was created about 5 years ago as a center of excellence for PAD and CLI care. I saw a problem in this community that we all share is the people with advanced critical limb disease. And we needed to figure out how to do this better. So critical limb ischemia represents the final stage of peripheral vascular disease progression, but it doesn't have to end in amputation like it did for this person or for this person. Something has to be done differently. This can't be the answer for advanced critical limb disease. So what's happening in our region? If we look at where VIC is right here in South Tennessee, we're surrounded by high areas of amputation rate. And it seems to be in the southern states the most. And so we need to do something a little bit different. So if we're going to change how we do this, I need to change your mindset. I need to change an attitude, maybe a behavior. Hopefully that will lead to action, results, and performance of how we care for these patients just a little bit differently. So this is what we typically get in the hospital consult for amputation. And I think the mindset's wrong. I think it should be no amputation. It should be for limb salvage. That's what the consult should be for. And so for the next 3 slides, we're going to talk about critical limb disease. This is a patient with Rutherford category 4 rest pain at nighttime, foot hurts. He has rubor to the foot. This is the classic sign of rubor. Rubor here, no rubor there. And so he has Rutherford category 4 disease. It's a little obvious, more obvious when there's gangrene of a toe or a wound that doesn't heal, and then very obvious when part of the foot is gone. This will require major surgery. This is Rutherford category 6. So if we look at the 5-year mortality rate of people that are diagnosed with critical limb disease, and we compare that to the 5-year mortality rate of all cancers, more people die from critical limb disease than all cancers in that 5-year period, except for lung cancer. Something to be aware of. If we're going to make progress for these patients and look and then perform surgery for these patients, if we do a major amputation on a critical limb patient or do a bypass surgery or an endovascular therapy, and we look at their survival, this is survival for bypass and endotherapy, but this is the survival for amputation. This suggests that there's a significant decrease in survival, and there are many studies that are showing this. We look at this index patient for me, which I performed, which I saw about 8 years ago. She had gangrene of her toe for about 2 weeks, presented to her primary care, then presented to me. And I saw her on a Wednesday. And by Thursday, she called me and said the gangrene, the blackness was growing into her foot. So I said, meet me in the operating room. We're going to take you to the hospital immediately. This was a 65-year-old white female, rapid progression of gangrene in the right foot. She has diabetes, hypertension, coronary disease, Rutherford 6, wet gangrene, and on the angiogram, she has a patent anterior tibial artery, dorsal pedal is gone, posterior tibial circulation is gone, so she essentially has ischemia to that forefoot. So from a surgeon's perspective, there's really no way to do a bypass to this. I can't bypass to an occluded artery here or bypass to this artery here. So the classic answer would be a below knee amputation. This is life-saving in the face of gangrene. But we chose a different option. We went through a subintimal approach where we use a micropuncture needle in this area. And you can see as the needle goes in, we can put a small little wire. That little wire travels up the artery. And as it travels up the artery, we can get to the arteries above that are open. We do that through a small little catheter like this, where the catheter goes in, and then we can reconstruct that posterior tibial artery. We can come back down this way and reconstruct the dorsal pedal artery. And so now we have flow into the foot. And I want to talk about what we call the angiosome concept. That means that different parts of the foot need the blood flow to heal that part of the wound. And so the best example I have for this is when my wife was trying to make multicolored flowers, I realized that there was a connection here. And so if we're going to heal that wound right here in red, we have to get the blood flow, that pipe that gives the red blood right here to that part of the flower or the foot. Nature works very similar in that fashion. So once we've reconstructed both posterior circulation, anterior circulation, the patient would have to have amputation of that great toe. There was gangrene. And this is 2 weeks later, a great healing ridge right here. And then at 6 weeks, she's completely healed that wound, and she has a salvageable foot. She can still walk on this, be active. So today, are we on a pathway to limb salvage in the US? I would say we still are not. Major amputation is the most often and the only treatment option offered for patients with critical limb disease. No attempt at revascularization in 60 to 73% of patients. No angiogram performed in 51 to 73% of CLI patients, despite a 90% odds reduction for amputation. So if I take them to angiogram, 9 out of 10 patients, we can do something to them and prevent their amputation. So that seems like that should be the way we do it. CLI treatment philosophy has to change. And one of the ways that we are trying to drive this is everybody knows about the FAST, an acronym for stroke. Well, we created an acronym for PAD critical limb. It's called FLOW. Feelings of pain in your legs, loss of sensation in your toes and feet, open sores that won't heal, or weakness when walking. These are the signs of a flow problem. And we tell our patients, be evaluated. So ask them about flow. Ask them if they have those problems. That will help define who needs to be further evaluated. So there's a patient that's a Rutherford category 4, a 47-year-old white male. He had pain, numbness in his right toes for 2 months. He had a past history of peripheral vascular disease, aortic occlusion. He has had an aortobifemoral bypass. He's 47. He's a significant 2-pack-a-day smoker for years. He has a palpable femoral pulse, popliteal, PT, and DP pulse, but he had 0 toe pressure at the lab. So what do we see on physical exam? What we see is very poor perfusion to this region of the foot. And we performed an angiogram, put a small catheter and a needle. We took pictures down into the foot. And what you see, he has a patent intertibial and postertibial. If you check the pulse here, he would have pulses. His AVI would be 1, but he has problems with forefoot ischemia. This lesion and this poor artery, this poor perfusion in this artery leads to what we call forefoot ischemia. So we can actually fix that by using different atherectomy devices, which we've talked about. This will clear out that blockage and then allow us to improve the flow into that foot. And in an AP view, we can see normal flow into that foot. So immediately post-op, his flow was co-dominant really now in both anterior, posterior. He had immediate pain and numbness improvement in the recovery area. So a clear sign of critical ischemia. Let's look at this Rutherford category 5 patient. 69-year-old white female, gangrene left second toe, history of hypertension, coronary disease, dyslipidemia, former smoker, palpable femoral pulse, popliteal pulse, but no tibial pulses. And here is the gangrene at the great toe. She had a shoe that was just a little too small and it caused a problem. And the angiogram showed the popliteal looks to be normal, 3 vessels come down, but the distal anterotibial had a critical lesion. And so we have different devices now that we can use to perform atherectomy at this level. One's called orbital atherectomy, one is called rotational atherectomy, more like a Pac-Man device, and then we could use laser to actually open that back up. After the atherectomy portion, we always use an angioplasty, which really develops that channel so the blood can flow back again. We also looked down at her dorsal pedal artery and had to fix that lesion. And 2 weeks later, she has a healing of that wound. At 4 weeks, great desquamation of the skin, normal tissue turgor. The wound is gone and she is clearly recovering from a Rutherford 5 lesion. So we've had some advances in technology as well. The new catheter is very focused, very sharp at the tip, and because of this, we can place them into smaller vessels like the anterotibial artery. So this is a patient where we have a critical limb disease here, ulcer, a non-healing wound, 6 months, and the ulcer right here. Preoperative testing showed he had a high-grade obstruction in the stents, and so we took him to surgery. This is typically how we set up at Vic and do this on a daily basis. So we found that he had an occlusion in this level. We reconstructed that, reconstructed the anterior artery. And this is what we see on the first shot of the intertibial. This is patent, but then it occludes. We reconstruct that vessel. We move up to the SFA and popliteal, reconstruct this vessel. And now we have flow through the SFA and popliteal. And remember the angiosome concept. We had anterior circulation, but in this patient, we needed to fix that posterior circulation because of a wound on the bottom of the foot. So with that, we performed angioplasty. And this is the typical flow that we typically see after these procedures. We want to see that amount of flow. That will lead to success for these patients. We use a small closure device that is just gauze and a little bit of tape, and we leave that on for 24 hours. Most patients can leave after about an hour, hour and a half, and then take the bandage off after that. We've also had some advances in knowledge, and we've had one of the world leading experts come to us today and talk about plantar acceleration times and pedal acceleration times. And Jill Somerset designs a lot of this. And so we're going to apply that to this patient right here. So do we have enough perfusion to heal? Well, we talked about the angiosome concept of getting blood to the top and the bottom of the foot. But is it enough? And that's really the question. Do we have adequate perfusion to heal? And that's where plantar acceleration times come into play. Jill showed us her anatomy, how she does it, the different areas where she looks, and then we have a normal pattern of circulation here, and then a very abnormal pattern. And we can stratify that. And when we stratify that, we can talk about applying that to patients clinically for determination of perfusion. So in this 73-year-old white male, he had gangrene of the third toe for 3 months. He had an acute MI, and he had carotid surgery and diabetes and dyslipidemia. He had a very sick gentleman, former significant smoker. They had a palpable femoral pulse, popliteal, but non-palpable pedals. So do we have enough perfusion? Let's look at the physical exam portion. When we push, you see the blood come back into that foot. Anteriorly, it's a little bit more sluggish, I push, and it comes back very slowly. So it makes you a little bit more concerned that it may not be adequate perfusion. ABI is 1, but that can be falsely elevated in a diabetic. And when we look at pedal acceleration times, they're completely abnormal, both anterior and posterior, what we call class 4 ischemia, consistent with critical limb disease. So what we did was we took him to surgery, found the blockage and reconstructed that vessel. And this is the SFA and the popliteal. The TP trunk right here and the perineal is occluded. And we reconstructed that perineal artery into the foot. Now, he has no AT and he has no PT, but we were hoping that the perineal was good enough. And fortunately, the rest pain was resolved. His artery was widely open now. But again, he has no direct connection to the foot. So does he have enough perfusion to heal? And so pre-op, he was class 4, anterior, posterior. He's now class 2 perfusion anterior, but class 4 posterior still. Well, that would suggest that he might not heal. And that's what happened when he had toe amputation. And he had this non-healing edge necrosis and this wound that was just simply not healing from a posterior circulation problem. So what we did was we reconstructed we entered the dorsal pedal artery, reconstructed the anterior tibial, and that connected to the popliteal. That improved the flow now to the foot, and his PATs were in class 2 and class 3 perfusion. And you can see that he's starting to heal here, contracting wound, and this is healing nicely. So an example of limb salvage for a very sick gentleman. So I want to invite you to the community network for critical limb disease. When a patient enters into the circle somewhere, primary care, endocrinology office, or emergency medicine, we've got to activate the right people to be involved. That's generally podiatry or interventional vascular surgery to fix these problems. We'll need primary care, we need endocrine or cardiology or infectious disease in some of these patients. We'll activate what we need so that we can save the limb and improve survival. That is the name of the game. So no more amputation. We are the CLI fighters for this region, and we hate to lose. So please join our network. Thank you.